Yes, I can hear you.
Okay, I don't know. Some people are having problems with the audio. I don't know how to fix it. Um, Hopefully, a good number of you can hear. Okay, thanks, Carol. Anyway, the thing I was going to say to hear me, I knew a few of you are hoping to a good friend in our community passed away recently. So, Barbara, you're old enough to hear my hear me. Um, well, Sarah, go ahead and get started. I hope there are enough people who have good audio.
Okay, you were cutting up a little bit there at the end. Can everyone hear me
Hello.
okay now?
Yes, Sarah, I hear you loud and clear.
Okay, let me make sure that I do this correctly. Can everyone see my screen?
Yes.
Yes.
Yeah, does that work? Can you guys all see it well?
Yeah, it looks great.
Perfect. Okay. All right, I'll go ahead and get started then if that works for everyone. I don't know if it lets me go back. Okay. My name's Sarah. I work at NAC. If I haven't met you guys, I started last year. And so today we're going to talk a little bit about stinging insect hypersensitivity. I know, I finished fellowship 2 years ago, I guess now, last year. I don't know. It's all a blur. But I feel like I never really saw a lot of patients with it. And even now, I've seen a couple of refills, but I still typically have a lot of questions about it. And so I just kind of went through the practice parameters and a couple of other points. I spoke with Sean, who works over at Hollister Steer. And so I included some of their information regarding the Venom prep as well, which I thought was interesting that I had never seen before. All right, so these are the objectives. So a little bit of background: between 56 to 94% of the adult population reports at least one lifetime sting. In the US, it's estimated that systemic allergic reactions to insect stings affect up to 5% of the population during their lifetime and up to 32% of beekeepers. There's about 500,000 to a million. There's quite a few emergency room visits every year for what they kind of qualify as non-canine bites or stings. And over the kind of, anaphylaxis in general has been increasing over the last decade. And the stinging insects made up about 68% of those visits. And severe anaphylaxis, anaphylactic reactions account for about 40 to 100 deaths from stinging insects every year. It varies year to year. This is from the CDC website, and it goes over the deaths every year from stinging insect hypersensitivity reactions. So there's a lot of different categories of adverse stings. You have your local reactions, which are kind of just the localized swelling, usually peak around 24 to 48 hours after you're stung, and it can take a while, up to a week, to get better. Then you have your large local, which the incidence is about 4 to 10% of that. Then you have your cutaneous systemic reactions. So that's isolated to just hives, angioedema, itching, flushing, but don't have any airway involvement, no throat involvement, no cardiovascular abnormalities. And then you have your classic anaphylaxis, which is either hypotension or at least 2 organ systems. And then you have your fatal sting reactions, serum sickness-like reactions, or also toxic reactions, which can mimic quite a few things. And those are pretty rare. You have to get stung quite a few times in order for those to occur. There are several risk factors. This is from the practice parameter of that can predict kind of more severe sting reactions. So whether you've had a serious reaction before, presentation with no urticaria or angioedema, older age, so greater than 45, male sex, or having multiple or sequential stings and being on certain medications, as well as some laboratory markers, and we'll get into those later. So, ultimately it'd be nice to identify all the insects. It kind of, tends to be pretty tricky to do. People's memories aren't great, and it's very hard to identify when you do get stung. So typically we do the broad testing, but some things that you can kind of ask as part of your history, going over, what were you doing at the time of the sting? Where were you? If you saw anything, any specific characteristics of the insect, the time of year, if you were eating or not, and kind of where in the country you were, kind of what you were doing. There's kind of all of the Hymenoptera is kind of the broad category. And then within that, there's quite a few different families. So the four Mycidae are the fire ants. And so that's one category. We have the Vespidae, which are your yellow jackets, yellow hornets, white-faced hornets, and paper wasps. And then there's the Apidae, which is the honeybee and the bumblebee. This is a chart here. I won't go through, all the specific characteristics. I do remember on boards that they're pretty particular, and they usually have a picture of a hive or something on there that they then have you identify. But the kind of main four stinging insects, the honeybee, the yellow jacket, the paper wasp, and the hornet, some of them are more gentle unless they're disturbed compared to, the yellow jacket and the hornet, which can tend to chase after you, and they will also sting you multiple times. And the hornets actually kind of shoot venom out as well. And then some of them, tend to kind of mind their own business more so versus the yellow jackets and the hornets that tend to be around food and other containers. And so a lot of times your questions will have kind of, depending on what the person was doing, whether it was a picnic or whether they were hiking, you can kind of get some clues of potentially what it was that stung them. And then, bringing it back to 2020, there's the murder hornet, which technically falls into the, the hornet category. Interesting enough, there was a lot of talk about how poisonous it was, or, getting the name murder hornet. It's typically found in Asia. They had actually tested the LD50, just some fun facts, against that of other hornets, and it's actually pretty comparable. So they were looking at it on mice. And so the lethal dose, the 50% of the lethal dose was about 4.1 milligrams per kilogram compared to the honeybee, which is actually 2.8 for the same amount. The trick is, though, for the murder hornets, they can actually sting, multiple times. And there's enough venom in one hornet to kill about 10 mice, and a small colony can kill about a 150-pound animal. There's some interesting papers out of China and Japan regarding, the adverse events from the hornets. It does not seem like there's a higher risk potentially of anaphylaxis, even though you may get a larger injection. People are stung multiple times. Most of the papers that had multiple stings were like 20 to 100 stings. It has a unique toxin called Mandara toxin. And so high doses of that induce convulsions, constriction of airways, muscle weakness, and can also cause death. They're not really sure how it works. And then a lot of the life-threatening reactions, interestingly, are due to either acute interstitial nephritis, acute toxic hepatitis, or acute toxic myocarditis. And they treat it quite aggressively with supportive care. You might need CRRT or hemoperfusion or plasma exchange. So then going back to, the stingers, so there's barbless stingers, which are kind of these smooth stingers here, and wasps, yellow jackets, white-faced hornets, and yellow hornets, and bumblebees all have those. Those do not detach, and so they're able to sting you multiple times. That's compared to the barb stinger, which is what the honeybee has. And as you can see kind of in the other picture, you can see the barb detaching after they sting, and so they're only able to sting you once for the most part. And then we have fire ants. I grew up in Texas and got stung by a fire ant when I was little by accidentally stepping on a fire ant hive. And it is very, very, very painful, and they are very aggressive, and they will attack you multiple times if you accidentally step on them, and you get these kind of pustules afterwards. Here we don't have those. It's typically in the South that they are seen. So the management of acute reactions, just like any other anaphylactic reaction, you treat with early epi, supportive care, and going to the emergency room. Just like with food allergies, fatal reactions are associated with delayed epinephrine use. With your just cutaneous reactions, you can treat those with antihistamines and close observation. And large local, you can treat with antihistamines, cold compresses, analgesics, and if they're getting more severe, then oral corticosteroids. If possible, you can remove the barb stinger if present. You want to do that, rather quickly. You want to try to scrape or flick it away, though. You don't want to grasp it and pull it because it can break. And then with your toxic reactions, you've got kind of these physiologic effects that can mimic, allergic reactions as well. And again, you treat all those with supportive care. So if a patient does have a history of having a reaction, you try to educate as best possible to try to avoid stings. So things such as, avoiding bright colored clothing, flowery prints. You don't want to kind of flail your arms if you do see an insect. Avoid walking barefoot or with open toe shoes, wearing, appropriate clothing, long pants, long sleeves, cautious around like bushes or eaves or attics, and kind of, food containers, and then having insecticides on hand if needed, and being cautious when you're eating outside, making sure they have their EpiPen and they know how to use it, and then considering the medical ID bracelet as well. And so then just going a little back about venom immunotherapy in general. So it's been described as early as the 12th century with people, talking about bees and stings and what to do about them. The first kind of death per se about stinging insects was described in a paper it was published in 1814, where it says this person bit a wasp that had bit an apple that had a wasp in it, and it killed the poor unfortunate man within a few hours. Initially, the practice was to do whole body extracts, and that is what was actually used for quite a while. There was a really interesting article in the Academy of Immunology regarding Mary Hewitt Lovelace. And so she actually started, she was an immunologist at Cornell. And so starting in the 40s, she started to use pure venom extracts instead of whole body extracts. And she kind of wrote that she would go out, every autumn in a field, she would catch the wasps, she would anesthetize them, and she would remove their venom sacs. And then she refrigerated those for up to a year, ground them up, and then would kind of do bolus injections for her patients. She dissected a whole bunch, over 30,000. She thought kind of over the years. And then by the 70s, she had treated about 300 patients and would ultimately kind of seems like almost do like a rush immunotherapy type thing with them. And then they would come back every year. And for people that lived far away, they would actually find a way to like grab the animal on their own, and then they would sting themselves and when they were at home. Largely, though, that was not really in favor. It was really the whole ground body extracts until 1978. There was a paper published in the New England Journal, and they actually did a randomized control trial of comparing the venom versus the whole body extract versus placebo in different patients. I unfortunately couldn't access the original article, but in one of the board reviews, there's I remember watching the lecture, and I unfortunately couldn't find it, but there is this great chart of one of the people kind of talking about what they did during these trials, and something that, we wouldn't be able to do today, but pretty much they had these patients in the ICU, and they had, whether it was via or wasp, they kind of had it on their stomach in a glass jar, and then they would just agitate it until the person got stung. And there is this chart that shows from the moment of sting to then what happened afterwards. And it was, for some patients, it was within minutes that they had, or within seconds that you could see their blood pressure tanking, and they were in the ICU when this was done, and they needed intubation very, very quickly. And they actually stopped the trial early, to my understanding, because after 6 to 10 weeks, they looked at the difference on the sting reactions, and there was really no difference between the placebo and the whole body extract, but there was a significant difference in those that used venom. And kind of since then, that's been the standard, is to use the venom immunotherapy. And then this is from Hollister Steer. Let me know if you guys can see it. Hopefully it's embedded okay, but this is actually how they extract the venom now. And so then I also found this other article that kind of went over pricing. I guess, I think we didn't do a lot of venom at UCSF, and I remember there was the shortage a couple of years ago. But I found it interesting. I didn't realize that North America it's just Hollister Steer that provides the venom extracts, at least from my understanding. And it's interesting, it's obviously a life-saving therapy, but overall, the market is pretty small compared to other allergy medicines like nasal sprays, which make, billions of dollars a year. It was talking about people that are harvesters. And so they go out and they grab more than 400 pounds of these stinging insects. And depending on what the insect is, they can have, various prices. The paper wasps go for about $2,000 a pound. And then the yellow hornets and the yellow jackets are about 600. Okay. And so then did someone, okay. Then your major proteins in the hymenoptera venom, you have the honeybee venoms that have a standardized phospholipase A content, and then the mixed vespid venoms, which have a standardized hyaluronidase content. And this kind of goes over all of the different proteins. This is from the practice parameter. Okay. And so then the FDA, it's standardized for venom. And so the standardization is based on the measurements of the enzymatic activity of the different proteins. And these are the standards per Hollister Steer that is required by the FDA. So you have your hyaluronidase that's standardized for your mixed vespids, your phospholipase A for the honeybee, your protein, your sterility, the safety, the moisture, and the mannitol. And then this, again, from the practice parameter, goes over the cross-reactivity between the different hymenoptera. And then there's a couple differences between the practice parameter versus the package insert that comes with the actual venom immunotherapy. We'll kind of touch on a few of them, but they're kind of all mentioned in this table from the practice parameter. And there's a section on the practice parameter that kind of goes over the differences between the package insert as well as the updated practice parameters from 2016. And so your ultimate outcome, so really, the question for immunotherapy is, what's the chance of you having another reaction again, and what is your need to be treated with venom immunotherapy? So asymptomatic venom sensitization is found in actually about 20% of adults. 5 to 15% of these will have a reaction at some point in the future, but most will actually lose their sensitization over time. And so there's really no guidelines for empiric testing if you've never had a history of a sting before. Kids that are under 16 that just have cutaneous systemic reactions without systemic manifestations, there's a very low chance of having a systemic reaction after that. And so it's actually not recommended to do venom immunotherapy. For large local, there's a risk of about 5 to 10%. You can consider epinephrine, and if it's an unavoidable progression, consider VIT, but typically it's not recommended. And then you have your systemic reaction, which there's a 50 to 70% chance of having a repeat systemic reaction, and so that is the indication for VIT. And then about 50% of fatal sting reactions actually occur with the first reaction, and so there's unfortunately not much that we can do in that regard in regards to identifying those. And so this is from the practice parameters. Again, it kind of goes over, this is actually from the Quad AI board review book, but it kind of goes over kind of what the previous reaction is, what your skin testing or in vitro testing is, your risk of systemic reaction, and whether or not they should get VIT. And I think, on paper, it sounds really great and really easy. And you have some people that show up that have pretty classic, pretty severe anaphylaxis. And so those are very obvious. I feel like in practice now, I've gotten a lot of really gray zones or gray areas. And so I just wanted to take like a minute or two. I just finished my practice, and I also just kind of wanted to open it up to people that have been doing this a lot longer and just seeing, and then I'll talk about testing and the venom and the scheduling and stuff afterwards. But I was just wondering if anyone had any thoughts or kind of how you guys approach this otherwise for people that have been doing this longer than I have in kind of these fuzzy situations. I think, obviously when people get stung, there's a lot of anxiety. And so I've had quite a few people, have just a large local, but then they say, oh, my throat felt really tight, or, I don't know, I just felt like really funny, and then you're kind of in this limbo per se of what to do afterwards. So I just was wondering if anyone had any specific thoughts for myself or the fellows, and kind of clinically, since we don't tend to see these a ton.
Sarah, can you hear me?
Yeah, I can hear you.
Yeah, this is not answering the question you just asked, but in looking back to how tedious it is to prepare the venom sacs, and we know what the antigens are. Has anybody considered just synthesizing the enzymes that for virtually everybody are the antigens instead of going through that tedious process?
I was actually not even aware that this is how. I don't know. I assumed it was, I don't know. I never really thought about it. But not that I could find. I know Sean's on. I don't know if Sean has any insight on that or if they're doing anything at Hollister Steer in particular.
Dr. Altman, this is Sean. Sorry, no, that's not something that we've addressed yet. It's still just that pure venom is what we go to at this point.
Anybody
Sure.
even had that thought? I mean, what, well, the answer is no, it hasn't been thought of and it hasn't been done. Okay. As far as your question, yeah, there are always people that are in this gray zone, and you probably in certain situations wind up putting people on venom immunotherapy because you can't distinguish. They skin test positive, they have a history, and they had symptoms that you can't really distinguish from anxiety versus a real systemic reaction. So there always is a gray zone.
So do you err on the side of testing versus not testing, or kind of presenting? I've heard some people say, if you're going to test, then, if anything's positive, then they have to go on.
Well, I think the important thing is that people who only have had large local persistent reactions, we know their risk is small enough, and yet at least half of them are going to test positive. So you shouldn't test them, because if you test them and they're positive, then you're stuck.
Yeah.
That you almost have to put them on venom immunotherapy when it's not warranted. So I think that's the key thing, is to know that large local persistent reactions have IgE sensitization. If you test for it, you're going to find it, but you shouldn't do the test.
Anyone else have anything? No. Okay. So then when it comes to testing, you have the skin testing that's indicated for the subjects who are candidates for VIT. The parameters tend to prefer the skin test over specific IgE. In the past, they've said kind of, wait 3 to 6 weeks after a reaction. They actually found that about 79% of people are positive within the first week after their reaction. If you get a negative because you tested too early, then they always recommend, waiting greater than 6 weeks and repeating the testing. The remaining 21% will turn positive sometime, by 4 to 6 weeks after their original reaction. If it's negative, despite having, a strong history, then obtaining, blood testing as well. And we'll talk about that in a second. As with anything, the degree of sensitivity does not correlate with the degree of or the severity of the reaction. And then unlike the venoms, Bioreacts are the whole body crushed extracts that you use when you do the testing. The skin tests start at 0.01 micrograms per milliliter, and then your IDs can kind of range, but you can continue to increase tenfold up until 1, which is the maximum. Anything over 1 will just cause an irritant reaction. Your specific IgE, again, that has the false positive rate of about 20%. Interestingly, both the skin test and the serologic testing don't correlate 100%. So you have serologic testing that's negative in about 20% of patients that have a positive skin test, and skin tests that are negative in about 10 to 20% of patients who have a positive IgE. So again, having that history and kind of taking it all together is really important. And then your serum tryptase, it's recommended if you've had a very severe reaction, hypotension during your episode, lack of urticaria during a systemic reaction, or a systemic reaction to a sting with negative venom IgE. And then you can consider obtaining, if they have a systemic reaction to either this injection or to a sting during VIT before discontinuing VIT, or with any patient that's a candidate. And then in general, with elevated serum tryptase levels, the odds ratio, so now there's a lot more known kind of about mastocytosis and the risk of these patients. There is quite a lot more that's been found out kind of more recently regarding having elevated tryptase levels, and these patients actually having kind of going along with the insect hypersensitivity and having more severe reactions. And so the odds ratio for a severe anaphylactic reaction in relation to your baseline tryptase level, so it's a twofold higher if your tryptase level is kind of right at the cusp of what we consider normal versus elevated, which is 11.4. And then it's 5 times higher for those with a tryptase level of 20. Elevated serum tryptase is associated with more frequent and more severe reactions to VIT. Increased chance of treatment failure, either with defined as a systemic reaction to a sting during VIT. There's a higher chance of relapse if they stop VIT, including the chance of having a fatal reaction to sting after you complete VIT. And then there's a very high risk that every subsequent sting can cause a severe anaphylactic reaction, even in the setting of having relatively low IgE levels. And so the mechanism isn't 100% understood. There is some evidence of some venom-specific IgG antibodies, which kind of start around 2 to 4 months and kind of are constant throughout your treatment. They do block in vitro mediator reliefs of allergen-stimulated mast cells and basophils. And they've had honeybee allergic patients that could tolerate challenge stings with passive gamma globulin immunization or gamma globulin infusion from pooled beekeeper serum, who tend to have high titers of blocking antibodies. Ultimately, then, the desensitization process, you're shifting from a Th2 phenotype to a Th1 or a Treg phenotype. And then there's a reduction in venom-specific IgE. So it's thought to be potentially more of an epiphenomenon, not necessarily a therapeutic mechanism. Your dosing schedule, you start at 0.1 to 1 micrograms, and you kind of increase to the maintenance of 100 micrograms for specific insect venoms, or 300 if you're on mixed vespid. In the early kind of clinical trials, when they kind of came up with the FDA-approved doses, the 100 was thought to be equivalent to 2 honeybee stings, which is about 50 micrograms per sting. For the venom and the vespid in particular, there can be quite a variation. They have about 2 to 20 micrograms per sting of protein. And so some of the VIT actually ends up providing 5 to 50 stings, depending on what would be seen in the real world. You can consider, there's a lot of different modified methods, including using Xolair to get people kind of on rush and get started soon. The maintenance, with the most recent practice parameters, it used to be kind of, just Q4 weeks indefinitely. And then they've, had some studies that show that after 12 to 18 months, you can start to space out to every 6 weeks and then every 8 weeks. And then after several years, it's proven to be safe and effective to space them out to every 12 weeks. And then your fire ants is kind of a slightly different schedule. So the safety, so during the buildup phase, about 50% of patients will have large local reactions and 5 to 15% will have systemic reactions. The majority of the reactions tend to be mild and less than 5% require treatment with epinephrine. The efficacy is very good. So about 75 to 95% with maintenance dose of 100 and 95 to 100% with a maintenance dose of the 300 for the mixed vespids. Let me just make sure. Sorry. Okay, and then some medication considerations. So there is a risk of more severe systemic reaction to insect stings when you're, for patients that are not treated with VIT, who are on beta blockers or ACE inhibitors. There is conflicting evidence about whether the medications while you're on VIT actually increase your risk of anaphylaxis. And there's also, limited and controversial data on whether these medicines should be stopped, if they could be, in the 24 hours prior to VIT. Ultimately, the practice parameters say, VIT clearly outweighs the potential risks associated with the beta blockers and the ACE inhibitors in patients that have anaphylaxis to stings. And so they, say to proceed with it if possible. They mentioned in the practice parameters some other medications to consider. These are also on the package inserts of Hollister Steer, aside from the beta blockers and the ACE inhibitors, alpha-adrenergic blockers, tricyclic antidepressants, MAOIs, and possibly ARBs. And then if you're kind of on these medicines lifelong for other, your other medical problems, those patients may warrant kind of extended or indefinite treatment with VIT because there is an increased risk of relapse or having another reaction if you were to get stung after you stopped VIT. And so the duration, at least 3 to 5 years, most people are doing kind of 5 years. Some people are repeat testing. That's not necessarily indicated, mostly because some studies have shown that, people will have persistently positive skin testing, even in the setting of not having, having completed the venom immunotherapy. There are some patients, where it may just be worthwhile to continue on them indefinitely. That's particularly if they had a very severe reaction as their, presentation. If they've had any systemic reactions while on VIT, honeybee allergy, increased baseline serum tryptase levels, underlying medical conditions or concomitant medications such as the beta blockers or the ACE inhibitors, or if they have frequent exposure. Additionally, a lot of people, based on their lifestyle and what they do and the anxiety around getting stung, may prefer to stay on venom immunotherapy. And then less is known about the fire ant because the whole body extracts are just less well studied. And then this is through Hollister Steer to direct patients. And then they also kind of, it looks like, have pamphlets and stuff for the office. That's their Be Aware program. And so it has patient education, they have physician locators, and then they also kind of have, office materials as well. And then I just thought I would include kind of just a few other tidbits. So I don't know if a lot of you watch Netflix, but there is a documentary called Unwell, or I guess kind of like pseudo documentary. I don't know. So it talks about different wellness trends, and one of them is actually bee venom. And so when you Google bee venom, this is what pops up in this area. So just to be aware of what patients are doing, it's very popular now to include, to some degree, bee venom in face masks. The one that they talked about on Netflix is one that Kate Middleton herself used for her royal wedding. So there are these masks, and that one actually seems to have a decent amount of bee venom because it ultimately causes some localized swelling of your face. And so it looks like you got Botox or got fillers because it kind of smooths out your appearance. But just something to consider for, people that may have allergies to that. And then there was this, which is interesting. I'm surprised that we haven't encountered these patients, but we may. It's becoming very trendy. At least it looks like in the alternative medicine realm. It's called apitherapy. And so this is from one of the websites. It says that bee venom is an ancient practice backed by modern science. It not only treats Lyme disease, but it treats a broad range of chronic illnesses, which is somewhat concerning because these are the illnesses that are posted on their website, including mast cell disorder, which, we would not advise if someone truly had mast cell disorder. They actually sting themselves. And so this is a picture of someone after they have stung themselves multiple times with bees, and they sting themselves every day, and they do these courses to ultimately cure them of their chronic Lyme disease or whatever other, fibromyalgia or chronic medical problems that have been shunned from the Western medicine community. There are reports of people that have done this that had anaphylaxed and died, which is also talked about. But just something to keep in mind as people kind of seek alternative therapies. They have a very big Instagram following and have been talked about on Goop and a lot of the other kind of health and wellness websites. So just, something to consider. But this kind of is straight from their website and kind of attracting all sorts of patients who are clearly frustrated with, care that they may be receiving in Western medicine as a solution to their problems. And that is all I have, which I know is a little short. I know Mike had texted me, and he, I guess he has some
Can you hear me?
experience. Yeah, we can. Yeah.
Okay, I've been having trouble with my speaker, so I apologize. So you were talking a little bit about some of the gray areas. And so I was at Hopkins when they were finishing up and continuing some of the venom studies. And as you know, kids under 16 who have cutaneous only symptoms don't need to be tested and don't need to be put on VIT because their risk is pretty low. And they tried to do the same sort of study in adults, but they couldn't accumulate people because if you ask adults, they will always give you sort of, yeah, maybe my throat felt a little funny, or maybe I felt a little short of breath, where kids don't do that. It's just sort of black and white. Yeah, I had hives and otherwise I felt fine. So they could never accumulate enough adults that had cutaneous only symptoms to see if in fact they needed venom IT or not. So they just by default get venom IT. So adults are tricky. So that's all that I wanted to say about some gray areas.
Anyone else have any comments or questions or anything else? Or Sean, anything else that you wanted to kind of add from the manufacturing side of the venoms?
No, I think you did a great job. That video kind of explains that manual process. It's very interesting. If anybody's ever in the Spokane area and would like a facility tour, we'll gladly do that. Just contact myself and just come on over, see how we do it.
Oh, one other thing, if anyone in this field has not read the article, the definitive article that proved venom worked over whole body extract versus placebo, it's really worth reading. You know, they put whole body extract was a definitive treatment for a number of years. And so people at Hopkins were able to get access to venom. And so they did this study, and then they brought the people into the intensive care unit, hooked them up with IVs, and had anesthesiologists, pulmonologists, allergists, cardiologists there while they stung them using a syringe plunger. And the folks who were on whole body and the folks who were on placebo obviously had a rough time, and the folks on venom did well. But how rough a time, I don't think anyone really anticipated. You know, they had epi given over and over again, and hypotension was not affected at all. They needed IV norepinephrine and they need dopamine, and I mean, these people were hypotensive for 45 minutes, some of them. And and when they came out of it, they said, yeah, that's just how I felt when I was lying in the field, sort of thing. So, you know, without the treatment, it can be a pretty bad, you know, outcome for those folks.
Stop. Anyone else have anything else or needed to say anything? If not,
Well, Sarah, can you hear me?
yeah,
Yeah. So one important issue that you didn't discuss is duration of therapy. You just said 3 to 5 years, but it's not that simple. A number of years ago, I think Golden primarily and the Hopkins group looked at what happens to people after they stop venom immunotherapy. And at least my recollection is these people don't stay totally normal. They don't stay at 1 to 3% risk like the general population. Gradually over time, their risk of re-sting systemic reactions increases to something like 15 to 17%. I wonder if other people want to comment on that. So many people elect to stay on longer.
Yeah, Dave Golden found that the reaccumulation is about 2 to 3% per year, cumulatively.
And it's
But
worse
with
for
a,
people
with a
who have
plateau, I mean,
elevated.
it doesn't go up indefinitely like 50 to 70% the way it used to be before venom immunotherapy.
I don't know if he studied them that far out to say that. But 2 to 3% per year. And as Mary, I think, was going to say, is those who have elevated tryptase and such, their risk
Oh
is
no,
high.
I'm just listening. I'm not participating.
Yeah.
The other thing, historically, those of us who are old enough, there were a group of allergists at the time of that Hopkins paper who swore that whole body extract worked. They had used it through their whole careers, and they didn't give it up easily. A little like today's political situation. There were literally battles at the Academy meeting of people who swore that whole body extract worked. And I think part of the confusion was that they looked at beekeepers who got stung repeatedly and naturally immunized themselves, but some of them got whole body extract, and the assumption was that that was protective until that classic paper was done.
So I remember going to one of Dave Golden's talks at the Academy, like maybe 2 years ago. And I just remember that for people who don't have elevated tryptase and maybe did not have such severe reactions and who are on venom immunotherapy, their risk doesn't go up as much when they stop the allergy shots. But then the people that have like elevated tryptase, they're like in the 20% group that if you stop their venom immunotherapy, their risk of recurrence of reactions goes up to like 20%. So there's sort of this dichotomy, depending on and so I think if you want to stop someone on allergy shots, one, you have to go back to the history and look and find out, did they have hypotension? Was it a severe reaction? How were they treated? Was it in the field? And then you need to know what their baseline tryptase level was, and maybe even check a tryptase level if it wasn't done 5 years ago, 10 years ago when you first started them on shots. But really, I think it's based on their tryptase. If someone has an elevated tryptase, I would never stop their shots.
I agree. Those people should probably stay on indefinitely.
Right. And then, but you can also increase the interval between shots to like every 10 to 12 weeks. So technically, they're only coming in 4 to 5 times a year.
Right. Well, that's what I was just going to say. As opposed to years ago, I remember patients, unless they had really awful initial reactions, after 3 to 5 years, said, "Didn't you tell me I could stop now?" They've been coming in every month or so. And now when we have the discussion, patients say, this is not a big deal for me to keep getting it 4 times a year. I'm fine with that. So that's a very pragmatic management thing that is a lot simpler as far as selling the continuing therapy.
Yeah.
And I think it said that they had tried 6 months, but that was too much. That was too long of an interval to be protective. But the 12 weeks seems to, still be efficacious and safe at providing the protection.
Yeah. Early on, after venom was first put on the market, there was discussion of measuring IgG antibodies that were generated and even getting a ratio of IgG to IgE to determine if people were protected. Did you come across any of that? It's not recommended any longer.
Yeah, so I mean, really, it was mostly this that I think it was, there was a couple papers that are cited kind of in when they were doing the passive stuff, which is assumed to be from the IgG, and you can measure that. I didn't kind of look more into that per se, but it seems like the theory is there when they try to, passively give the passive immunization of the beekeepers who do have, have kind of desensitized themselves through multiple stings over the years. And it seems to block the reaction when they did that challenge. But I didn't look into specifically, the clinical availability of that. The
last slide that you showed of people stinging themselves.
Yeah. Yeah.
Where do they obtain can you buy
So
bees?
so there are people who, this is literally from a website of a program that you can go through, and they mail you the bees, and they give you an EpiPen, and they have tweezers and an EpiPen on hand, and then they show them how to sting themselves like multiple times, like on the sides of has to be along, the sides of your spinal cord, because of, so that's why it's done on their back and not anywhere else. But yeah, they like have all the bees, and that's what they pick them up with tweezers and sting themselves like multiple times. So, and there's also acupuncture that is done, instead of just using the regular acupuncture needles, they do it with bees stings instead at the like trigger points of the acupuncture. But both that kind of, stinging for Lyme disease or whatever, as well as the acupuncture, there are cases of death, anaphylaxis, that led to death from, and ultimately they kind of sensitize themselves, because it wasn't at first, these were people that had been doing it, and then they had an anaphylactic reaction. But if you want to look at some weird kooky stuff, that Unwell on Netflix has a whole bunch of, they have an essential oils one, they have some interesting things on there that people are doing and talking about and using.
It's a weird world.
Yeah.
Yes.
All
Absolutely.
right, thank you, Sarah. Any other comments?
Oh, thanks, Sarah.
All right. And the word of the day is venom. You guys need it. All right.
All right.
Okay. Have a good day, everyone.
Yeah.
So long, everybody.
Bye-bye.
Thank you.